Okay, we'll get started. I want to welcome everybody to the first pediatric grand rounds of 2022 and welcome back from the holidays. I'll turn it over to our Vice Chair for Medical Education, Dr. Sandrain Van Schaik, to get us going today.
Yeah, welcome everybody. It's really nice to be able to introduce our speakers for today. It's actually the second grand rounds, but last week was a shared grand rounds with the Department of Medicine. And I don't actually know that we sent out the link, but if people have missed it, the link is available through our wiki if you still want to see it. It's not on our regular UCSF Pediatric Grand Rounds YouTube channel, but on the Department of Medicine YouTube channel, since it was a joint grand rounds. Today's grand rounds will be posted on our YouTube channel and features Dr. Nita Thakur and Dr. Dana Long. Dr. Thakur is a physician scientist specialized in pulmonary and critical care medicine with advanced training in clinical research methods, social epidemiology, and implementation sciences. Her research program focuses on the short and long-term health effects of multi-level stressors, including air pollution, with special focus on low socioeconomic communities and communities of color. Her group, the CLEAR Lab, has linked multiple data types, biological, individual, and environmental, to demonstrate that social risk factors are geospatially distributed, disproportionately burden communities of color, and are associated with clinical relevant health outcomes. She's the co-PI of the PEARLS study, and I think we're going to hear more about that study today. Dr. Thakur and team recently received funding from the California Initiative to Advance Precision Medicine to further the science of PEARLS and examine the effective caregiver-child interventions to reduce toxic stress and promote family well-being. And she came to this work because as an adult medicine physician, she saw the toll that adversity, social and environmental, had on patients' health. She saw addressing ACEs in childhood when they are occurring as an important way to mitigate the toxic stress and health effects in her future patients. She's joined by Dr. Dana Long, who is a pediatrician with special interest in community health and engagement and in promoting health and in promoting equity in healthcare. In her practice, she loves supporting parents and caregivers, and her patients fill her with inspiration and awe. Her goal is to enable all children to be as healthy as possible by eliminating the inequities that lead to poor health outcomes for many children's families and young children. Dr. Long's research and advocacy examines ways to make communities healthier, such as shifting traditional healthcare practices to team-based models focused on prevention. She earned her medical degree from the George Washington University School of Medicine and Health Sciences. At UCSF Benioff Children's Hospital, Oakland, she completed a residency in pediatrics and a fellowship in infectious diseases. She has additional training in incorporating cultural humility into patient care. She also shares that in her free time, she loves spending time with her three sons. And one of the highlights of her career was meeting former President Barack Obama. And with that, I'll hand it over to Dr. Thakur and Dr. Long.
Thank you for that introduction. We are thrilled to be here jointly. I was just remarking to Dana that I was remiss that this had to be virtual because of the Omicron surge, because I don't often get the opportunity to see Dana in person, and know, as all of you know, that during this pandemic, having those social connections is really important. Today, we'll be taking everyone through some of our work on childhood adversity, with some specific attention to the PEARLS study, which Dana and I both co-lead. And then also kind of talk about some more practical implementation where you all are seeing your patients and thinking about how you may be able to incorporate screening in your own practice. Before I start, I'll just state that my partner used to work at Genentech, and we have some unexercised stock options with them. And Genentech Corporate Giving is one of the funders for the PEARLS study. Dr. Long has nothing to disclose. Some of the objectives that we'll walk through today is describe the evidence that connects adverse childhood experiences, or ACEs, with poor health, including in childhood health outcomes. Discuss our process of developing and implementing a screen for ACEs, so this would be the PEARLS tool, in pediatric primary care with families and with practicing providers. And then lastly, understanding the impact of developing clinical interventions with diverse patient populations, and then discussing some of the health findings associated with ACEs within these populations. I personally like to start with a story to help contextualize why we're having this conversation today, particularly around ACEs. I often know that, or have seen that the presentations on ACEs have often been really based in the scientific literature, which is really important when we are trying to make an argument for change and why we should care as clinicians about this. But I do think it's always important to go back to our patients when we're thinking about how we may approach them and how we may approach their care. So this is Yana Hill. She lives in the Bayview, a community in San Francisco, as many of you know, that was built over industrialized land. Its geographic borders are freeways, and it has a higher prevalence of violence and poverty than the rest of the city. Due to historical events and policies, this including redlining and also the gentrification of the Fillmore area, this neighborhood is home to one of the highest percentage of Black individuals in San Francisco. I share this background because I think it's important context when thinking about Ms. Hill and her health. When Ms. Hill was 18 years old, she had a severe asthma attack at school. She's a senior in high school, was at her lunchtime and just started feeling very short of breath. And she took her inhaler without any relief. And then she took it again with really no improvement. The school called the emergency services. The EMS took her to SFGH, and where she stayed there for a full week for an asthma exacerbation. And as you know, that's a really long time, especially in pediatric care for asthma, but she needed it. She had to stay there for one full week for management of her asthma exacerbation. At first look, we could walk away from the story of Ms. Hill and say this is just a story of uncontrolled asthma, needed to work on our medications and keep going forward and moving forward. However, when you learn about what it took and what really worked for Ms. Hill to get her asthma under control, I think it's more of a story of stress and exposure to adversity. So after she was hospitalized, Ms. Hill started going to the 6M asthma clinic, which is actually a really innovative model of care and modeled after a social community partnership. So what does that mean? It means when a patient comes into the 6M asthma clinic, they meet with the community health worker who goes through not just their asthma control and their medications, but also their social circumstances that might be contributing to their poor control. It also involves a home visit, which provides understanding of where medications are located in the home, also an environmental scan of the home, and also connection to resources. And it was through this comprehensive care model and through these social partnerships, which also includes a medical legal partnership, that Ms. Hill was able to get her asthma under control. So when I reflect on Ms. Hill's story, I find a couple of things interesting. First, as a scientist, I find it interesting that she didn't respond to her albuterol. And this is something that has been demonstrated in research, that there is a difference across racial and ethnic groups to the response to albuterol. Many have contributed to differences in genetics. I question this, and I'll go into why in a short while, given what we know about stress. I also find it interesting, both as a clinician and as a researcher, that it was a social intervention. What she needed to get under control. So let's talk a little bit more about asthma. And this is just more to, again, put in context our conversation around ACEs and ACEs screening. So when we look at asthma by different racial and ethnic groups, we see a striking disparity. We're both African American, American Indian, and Native populations have a higher asthma prevalence than all other racial and ethnic groups. When we look across Latino subgroups, we also see that there is higher prevalence, particularly among Puerto Rican and Dominican populations. What we also see is that we also see differences in drug response. And this is what I made reference to on the previous slide when talking about Ms. Hill's case. And what we see here is that for short-acting bronchodilators, that there is a decreased response among our African-American participants, which is showed here in blue when looking at long-acting bronchodilators. We also saw, though, in a separate study that stress and reports of stress are also associated with a reduced response to bronchodilators. And so when we take a step back and think about this slide in particular, and when we talk about racial and ethnic disparities, we also have to think about the context in which they're occurring. I could show another slide that also shows that the asthma prevalence varies by socioeconomic status. I could show another slide that shows that it varies by exposure to air pollution. And these are all things, are all contextual factors that tend to concentrate in exposure with particular racial and ethnic groups in the United States. And I find this one study really, really instrumental in trying to describe the mechanism and looking about stress response and bronchodilator therapies, particularly for asthma. And this is from Chen and Miller at Northwestern, where they showed that there was a difference in beta-2 agonist receptor expression in children with asthma. So we know stress causes a response. It causes our adrenaline to release, which are catecholamines that activate different parts of the body to respond. In the lungs, this activation causes for the airways to open up. And what they found is that in healthy kids, if in situations where there were higher stress, in those kids, they actually had more beta-2 agonist receptor expression. So as expected, the stress led to increased expression of this receptor. However, in kids with asthma, the opposite is true. So now here is a potential mechanism of showing the downstream effects of long-term stress exposure for children that are in high stress circumstances and how it may connect to a disease outcome. And in this one in particular, connects to a drug response, and one that we consider the mainstay rescue therapy for asthma. So might be a potential pathway of why we may see disparities in asthma by across socioeconomic lines and then also across different racial and ethnic groups. So now this brings us to ACEs, the main topic for our conversation today. When we talk about ACEs, we're referring to these 10 categories of adversity divided into abuse, neglect, and household challenges. We'll talk about the additional domain of social determinants couched under the term related life events with the PEARLS tool, but wanted to just center us around ACEs first. And then talk about how with ACEs, we're also talking about the stress response. And what we're talking about is particularly is toxic stress. So just to kind of go through the different stress responses to get us all on the same page, positive stress is the type of stress that we think is actually helpful for health. And it's also protective. It's an evolutionary adaptation over time to ensure that we can run away from the bear. It also is what I feel and like giving a talk today. You know, my heart rate gets a little bit higher. I'm like ready to go and alert while giving this talk. Tolerable stress is what many of you might be experiencing during residency or during when going through medical school. It's that stress that's more long lasting, but it's buffered by supportive relationships. And that's a key point here is that tolerable stress, even though it may be longer lasting than other types of stress, it's buffered. Toxic stress is when the adversity is more prolonged and that there is also the absence of protective relationships. And this has impact on your biology. And these events happen in the context of what's going on around you and where they may be mitigating factors or buffering factors. And so these adversities can occur over the life course. Even in utero, there has been good evidence where stress during pregnancy can lead to poor health outcomes in childhood, and then early childhood and adolescence, these experiences are occurring. These experiences interact with one's biology. And that interaction, if there's no buffering by protective factors, can lead to toxic stress, leading to changes in our physiology. And there's a lot of different examples of how. One can be termed as allostatic load, where you're seeing wear and tear across micro changes across different biological systems, such as the neuroendocrine, neurologic, and metabolic, cardiovascular, that can lead to changes. These could also be reflected in changes in the microbiome or epigenetic modification. And this increases disease susceptibility, and then over time increases risk for disease and for disease morbidity over the life course. In fact, in one of the pivotal studies that first demonstrated that ACEs was associated with poor health in adulthood. And here's some of the summary of some of those results over time from research publications, of showing how the report of ACEs in childhood is associated with a variety of behavioral and physical health outcomes as an adult. And so we see that it's associated with a 32 times increase in learning and behavioral problems, 4.5 times increase in depression, 2 to 3 times increase in asthma, heart disease, and cancer, an increased risk of COPD. And in fact, if you were to look at the leading causes of death in the United States, 7 of them are associated with having 4 or more ACEs in childhood. And so this is, when you take a step back and you kind of think about, okay, from a population health perspective, ACEs are a big deal. They are reflecting of the context and the situation in which a person was brought up in. And those experiences early in life have big impacts on adult health. And, as mentioned in the intro, this is why I got interested in ACEs. I mean, if you take a step back, I'm an adult practicing pulmonologist, right? Why would I care about pediatric interventions and in general primary care? Well, this is why. I see the patients with COPD, I see the patients with asthma, and in my conversations, I learn about their childhood adversities. And so, due diligence, my public health hat on, it is imperative that I think about this and caring for my patients, but also think about strategies of what we can do to help prevent the long-term health effects of these. And so going back to Ms. Hill, we actually now have evidence that ACEs the report of ACEs is associated with the development of asthma in childhood. And so in this study, they looked and through a national study and found that each increase in the score of reported ACEs was associated with increased odds of asthma in childhood. So starting to show that it's not just something that will happen later in life, it's actually impacting pediatric care now. And so we wanted to take a deeper dive, both in trying to understand the biologic embedding of ACEs over the life course, but also more pragmatically, how do we even do this in primary care? Like, how do we screen? What are the ways we should intervene? Like, how do we even approach this? And so this was undertook by us at UCSF, the School of Medicine, with Benioff Children's Hospital, Oakland, at that time known as CHO, and then also with the Center of Youth Wellness under the guidance of Dr. Nadine Burke-Harris. And we all partnered together and formed the PEARL study. And the Pearl study had a few goals. One was to try to better understand whether screening was something that could happen in pediatric primary care, and trying to understand what was the best way to screen in primary care and how would that affect disclosure rates. The second was to understand different characteristics that were associated with disclosure in pediatric primary care. And then lastly, is this idea of trying to understand how the report of ACEs in childhood impact current pediatric health outcomes and also biological responses. And so to develop the screener and then also think about implementation, we undertook a large effort to review all of the available screens that were being used at that time. We then talked with our patients and their families about how they wanted to be screened. How would they like the information to be gathered? How would they want it to be incorporated into the EHR? And then what were their expectations about what we in care would do and respond to those screens? Lastly, we engaged and trained staffs and providers on this tool, and to ensure that there was uniform training and an approach to screening and response. So this study took place at the UCSF Benioff Children's Hospital, Oakland, as many of you know, a federally qualified health center, where the majority of patients there are people of color, predominantly Black and Latino. Over 90% live at or below the poverty level. Excuse me. The families that could participate had to be coming for a well child's check, and the participants were between the ages of 3 months and 11 years of age. The caregiver participants had to be 18 years and older and speak English or Spanish, and thought of as BCHO as their primary care center. The tool that we use is called the Pediatric ACEs and Related Life Events Screen. This includes those 10 categories of ACEs that I showed previously as part 1. And after the scour of the literature, we added a 4th domain for related life events that covered food insecurity, housing instability, discrimination, and community and violence, understanding that these areas also impacted the stress response and also likely contribute to poor health along a similar toxic stress effect that I showed previously. For the study, we had a total of 555 children enrolled. A third of them were screened or were randomized to no screening. And then that left us with 367 participants who were randomized to 2 screening arms. One was asking each item on the Pearls tool and asking for a yes/no response, which we refer to as an item level response here. The second was asking for, of all of these items that you see here, how many has your child experienced? And so this is the aggregate level response. And then with that, we looked at both the Pearls disclosure rates and then trying to understand people's reactions to their preferences around the identified or item level response versus aggregate level response. And then lastly, we looked at health outcomes. So here's the report. You can see that overall that the prevalence of reporting Pearls items was high, and that you can see that the aggregate responses are in light gray, with item level responses being in dark gray. And overall that the rates of disclosure were higher in those that were asked in the aggregate response. And one thing I forgot to mention on the previous slide is that those that underwent the aggregate level screen afterwards with the mental health practitioner were asked about each individual item so that we could identify which items they were endorsing under the aggregate level. So that's what this data is showing, is the after we asked those particular items. So 76% of the population reported at least one adversity, 39% reported 4 or more adversities. And then by format, we see here that the PEARLS disclosure rate was significantly higher in the item level response compared to, in the aggregate level response compared to the item level response, and that this difference in disclosure was more pronounced in children that identified as Black or as male. And this may have important implications when screening for in your practice. When we did our qualitative work, what was interesting was 70% of interviewees stated that they actually had a preference for an item level response because it provided more specific information to the provider. And then 12% expressed a preference for the aggregate level response. So there's a little bit of discordance in what we're seeing, right? Our disclosure rate was higher for the aggregate level response, yet the actual caregivers were saying that they preferred the item level response. I think the answer to this comes from our qualitative data. I think the disclosure rates between item level and aggregate, there would be a preference for item level if if we were able to meet their outcome expectations. So, you're going to screen me, but what happens in response? What are you going to connect me to? What kind of resources are connected with screening? The second is the quality of the provider and patient relationship. So trust definitely would lead to an increased preference for an item level response. And then lastly, I think it depends on where that caregiver is on that day of screening and how closely had those adverse childhood experience events have occurred for that child. And so all of these contextual factors definitely play a role in preferences for having for screening in clinic. What we also learned is that the report of having one or more PEARLs on the screener was associated with behavioral and health outcomes. And remember, this is a 3-month-old to 12 years of age. So earlier to mid-childhood and already seeing connections. So what we saw is that compared to children that had less PEARLs, those that had greater PEARLs, so this is with each increasing score, that they had more reports of poorer perceived health as measured by the PROMIS tool. They had greater problems with executive function as measured by the brief. They also had greater reports of stomach aches and were more likely to have asthma and eczema. So definitely relevant for care and also associated with relevant pediatric health outcomes that we're thinking about and caring for in practice. And so with this, I'm going to shift the talk over to my colleague, Dr. Long, to take us through the process of thinking about and implementing screening into practice.
Thank you so much, Nita. And as we think more about the clinical ramifications of the research, there are several elements that I want to point out to the audience. The first is I want to underscore how fantastic it has been to work collaboratively. We talk a lot about UCSF and being one UCSF and how thinking together, we can actually elevate the thinking of the entire institution and make huge change across not only the state, but the country. And working with the Department of Pediatrics, particularly within our Fairly Qualified Health Center, partnering with the School of Medicine allowed us to understand how the molecular is actually affecting the clinical outcomes and affecting population health. I also want to share that what Dr. Talker was just referring to is only one phase of our study. our Pearl study is hugely ambitious. And for the initial study that we implemented from 2013 up until December of 2019, the screening was part of our first set of randomizations. We had a second randomization after we drew biomarkers on our children to then randomize children to interventions in order to prevent, heal, and treat the effects of toxic stress. And we're hoping to come back and share that data in the future. And as we were generating the science, there was a huge amount of expertise and advocacy that was happening on a state level. So starting in 2019, myself and some of our partners from the Center for Youth Wellness were also asked to be part of an expert group that was helping to inform our state legislator in order to pass a legislation called AB 340. And AB 340 essentially provides incentives for providers who see patients with Medicaid across the state of California to be reimbursed for screening. That bill would not have passed without the very fastidious science that Nita and I were helping to lead, and many others were leading across the state. And this is an amazing example of how UCSF, how us as clinicians, how us as scientists are actually helping to truly transform the practice of medicine. As we were sitting within the state legislator and providing the evidence to guide policy, we really had to think about what is the rationale, what is the value for screening, and be able to actually then provide the data, much of which came from our Pearl study, to show that screening for ACEs and toxic stress actually improves the efficacy and efficiency for us as healthcare providers. If we can intervene early, not only can we improve patient outcomes, not only can we better support individuals and families, but we can reduce long-term health costs. Our study started before COVID, before Omicron, and I think that we are all traumatized, right, across the board. And when you can actually talk about the pain, talk about the hurt, you can give it words, you can normalize it, you can reduce stigma and judgment, and it opens the door to healing, right? By being able to have these conversations in primary care, you can give words to the pain and ultimately get to a place where we as providers and our families can recover. Next slide. There's a big role for us in primary care, and that role has now luckily also been endorsed by some of our national institutions. And so the National Academy of Science, Engineering, and Medicine in 2019, they came out with a policy statement that recommends the adoption of screening and trauma, screening for trauma and adversity early in life in order to increase the likelihood of early detection. And we also know that when we screen adults, we can also improve their ACE-associated health conditions, and it offers the ability to prevent the vertical transmission of ACEs and trauma from one generation to the next. Next slide. As primary care physicians, our role in this is huge, right? Our role is that we have to understand the science and the implications. And so that way we can treat the physiology and the symptomatology. It has to be done in a way that creates trust, that builds relationships, that is trauma informed. We want to do it in a way that actually empowers families to identify their own strengths, their resiliency, and their coping strategies. And again, this is more important than ever right now. And we want to be able to understand the linkage between underlying physiology of toxic stress, health concerns, and the management of chronic conditions like Ms. Hill and her asthma. Next slide. So what does this look like on the ground, right? We had to take the science and then understand in a busy safety net, fairly qualified health center, what are the key elements of clinical workflows that will enable us to do this, not only in our clinic, but that clinics across the state can also do this. And so those workflow elements include a lot of questions around how do you administer the tool? Who administers it? Where does it get administered? Once it's completed, how does that tool then get to the provider? How do we actually score it? How do we understand then what that score is in relationship to the clinical presentation? How do we create follow-up plans? How do we document and track? And then how do we bill? And so at the state level, we created through an initiative called ACEs Aware that is led by Dr. Brooke Harris and the Office of Surgeon General, as well as the Department of Healthcare Services. We had a clinical implementation statewide committee, and that committee worked on an algorithm based upon these elements of workflows. Next slide. And so that algorithm, it starts with understanding in a way that then can be manipulated by each individual clinic. Is it an LVN? Is it registration staff who administers the tool? Once it is administered, then does it go on the door? Does it actually get handed to the provider? Once it gets handed to the provider, how is that score then entered into the EMR, and how do we document it? When the provider sees the score, we also worked on what we refer to as the ACEs and Toxic Stress Pediatric Risk Assessment Algorithm. A 0 does not mean that the child has not experienced trauma. Right? A score of 0 might mean that the family doesn't feel comfortable disclosing, that it's just not the right time, or that there's just not enough trust that's built. And so even when a family says that their Pearl score is 0, the recommendation is to really provide education and tutorial guidance on ACEs, toxic stress, and buffering or resilient factors. And that includes safe, stable, nurturing relationships and environments. If the score is a 1 to 3, it's important to know, are there underlying physiologic manifestations of toxic stress that are already occurring in that young person? And so you want to know if there are associated health conditions. If the score is a 1 to 3 without associated health conditions, then their determined follow-up is to really provide education on ACEs, toxic stress, and resiliency. A score is considered high risk if it's 1 or more with associated health conditions, or 4 or more regardless of if there are associated health conditions. And if a child is determined to be high risk, it's much more than just the education. It also is linking a family to resources that can help to support the mental health and stability of the family, help to reduce social and environmental factors as much as possible, and to make that plan something that is jointly formulated together. If the score is unknown because the family simply does not want to complete the screen at all, that is also okay. The recommendation is that we still provide universal education around ACEs and toxic stress, and we re-offer the screen at the next physical. The cadence of screening in the pediatric realm is that we actually screen kids annually, and once a child gets to be at the age of 21 or older, that adults are screened once in their lifetime. So here is the pediatric clinical flow that I was referring to, which is a very generic algorithm that each clinic then can fill in and put the names in for who these people are. Next slide. We wanted to know what are the odds ratios of symptomatology or health conditions based upon ACEs score. And you can see on this ACE-associated health conditions in pediatrics, we also have ACE-associated health condition for the adults, as well as now we have one for our pregnant mothers as well. What we know is that, for instance, if your ACE score is 4 or more, you have a higher odds of having depression, ADHD, allergies, and asthma. And so in order to manage these health conditions, we really need to think about how are we managing the stress and trauma that children are facing. Next slide. When we respond to ACEs, there are 5 really critical elements for what that clinical response will look like. The first is ensuring that we really apply these principles of trauma-informed care in ways that are establishing trust, safety, and collaborative decision-making. And this is actually incredibly hard to do. And a lot of it comes from training and education. And right now with Omicron and COVID, a lot of our ability to be trauma-informed is our ability to be present and to self-regulate and to practice mindfulness. We want to make sure that we're supplementing our usual care for ACE-associated health conditions with patient education on ACEs and toxic stress. When I am sitting with a family who I'm trying to manage their child's ADHD and talk about how stressors might be impacting behavioral health, and we go through the ACEs score, over and over and over again, there's this palpable moment that happens in the exam room. And I refer to that as this moment of knowing. It's as if families feel it in their bones, right? We know, as an African American, we know the historical trauma that we have carried on for generations. We understand that even if a child can't verbalize the stress from seeing police violence or knowing that they have a family member and a loved one that's incarcerated, we are all carrying that it gets underneath our skins. And I hear from parents, why didn't I know this sooner, right? Why didn't I understand that this stress is actually making my son's asthma worse or contributing to my own depression? We want to validate existing strengths and protective factors to really be able to connect families to resources. And this is where care coordination and navigators come in. And then to follow up. And it seems like a lot during well visits to have to do the screening and have to respond. But the truth of the matter is that we have relationships and we have time. And it is okay to say, this is a really important conversation and I'm going to have you come back in 2 weeks so we can talk about it more then. Next slide. So when we respond, there are really 3 guiding principles, and these principles come from Dr. Jack Shenkoff's group, the Harvard Center for the Developing Child. And I want us to keep this in mind because all of our interventions, they might look different, but they should have these 3 elements. And those elements are really being responsive to relationships, and that includes our relationship as a healthcare institution with community, our relationship as providers with our patients, as well as the relationship between the adult caregiver and the child, to try to reduce the sources of stress, and then to make sure that we are improving capacity and core skills to actually be regulated in environments that are often chaotic as they are right now. Next slide. So I want to share a couple examples about how these three principles can actually play out in the clinic environment. And so when I talk about sort of supportive relationships, a lot of that can come from the education that we give as providers. During our study, during our pilot, we interviewed providers, and these were attending physicians as well as residents, and we asked them, what would you like to say to families after you screen them for ACEs? And we then collated those themes. And based upon that thematic analysis, we came up with this mnemonic that we call NOTE. And I actually keep this note in my back pocket all of the time. And I constantly rely on it to keep me grounded in the conversation. And so the N stands for to really notice the relationship and the strengths of the caregiver and the child, and to make sure that we comment on it. And so it might be that you say, I love the way that Joaquin looks at you and smiles every time that he sees you. I love the way that Susie wants to sit in your lap. I love the way that she always wants to give you hugs, right? Comment on that strength of the relationship. And if you're dealing with a teenager, it might be the strength of the relationship between that teen and a caregiver, or that teen and her girlfriend or her boyfriend. We always want to make sure we offer the science. And again, language is just so important. And so I say, what we do know is that stress affects our hearts, our minds, and our bodies. It affects adults, but it also can affect children. That we have tools in this clinic, and these tools are, whether they're resources or education or connecting to other referrals for management of chronic illness, and that you want to empower the family. I was recently working with a resident who was screening for the first time, and we went over this mnemonic, and we got to the empower piece, and I said, there's a lot that you can say under empowering, but keep it simple, right? You are a good parent. You're doing a good job. I know that times are really tough right now, and I see you, and you are incredible, right? And so the resident was going through this mnemonic with a family, and she came out of the room and I asked her, how did it go? And she said the mom started to cry. And at first I was like, oh goodness, what happened? And the resident said, the mom started to cry when I said that she was a good parent, because she had never heard that from a doctor before. And it just meant a ton to her. Next slide. So beyond anticipatory guidance, when we think about how to support children and families, there are evidence-based strategies for toxic stress regulation. And this graphic that you see actually comes from the Roadmap for Resiliency, which was published by the Office of Surgeon General and DHCS. And it's based upon these 8 pillars for toxic stress regulation, all of which have deep science, right, that are related to them. And the first is about leaning into supportive relationships, quality sleep, balanced nutrition. And the balanced nutrition, I really appreciate, because it talks about how, as Dr. Talker had referred to, when your adrenaline and noradrenaline and catecholamines and your cortisol is being dysregulated, is upregulated, you have these cravings for high fat, high sugar foods in order to keep that blood sugar up. But that really is counterproductive and can feed into poor health outcomes. And so understanding how the things that we eat are being dictated by our biologic drives. It talks about physical activity and mindfulness practices. And when we think about mindfulness practices, I often will just choose 1 or 2 to go over with families. And one of those mindfulness practices is called 4-1-5 breathing. And so it's about sort of grounding your feet and getting yourself centered. Ideally, you'd be barefoot if possible, so you can feel the ground under you. And that you teach, and these are very young children that can understand how to do this, right? You teach them to breathe in to the count of 4, to hold it for 1, and then to breathe out for the count of 5. And so being able to have really robust tool belts with practices that we can educate really gets to that third response, which is about capacity and skill building with families. The other strategy is access to nature. And here I want to give a shout out to our colleague, Dr. Nushin Razani, who is just being miraculous in building the evidence for access to nature and understanding that when we can get outside in green space, it actually does lower our heart rate and lower our blood pressure. And then mental health, and we all need mental health support right now. So understanding not only how to create referral pathways to our mental health colleagues, but understanding what those community pathways look like as well. Next slide. The other intervention that we're using a lot within our Federally Qualified Health Center in Oakland, and I know that there are variations on this in San Francisco at SF General, is this idea of community health workers and navigation to help with unmet basic needs. And so on the Pearl screen, we do have a part 2 that talks about food insecurity and housing instability, and being able to connect patients with community health workers. It not only allows you to resource families, but it also helps to build relationships and trust with the healthcare system, because oftentimes community health workers themselves come from the community, speak the same language. They themselves have often utilized resources. When we query ourselves about what resources our families are most needing help with, over and over and over again, we understand that food insecurity is huge. About 30% of our patients are food insecure at any particular time. Our families do need a lot of support around housing instability, help with activities for kids, help keeping their basic utilities on, medical legal concerns, including immigration and evictions, help with childcare, and during the pandemic, we provided a lot of support around internet and devices. Next slide. We also have primary care-based mental health interventions. And one of the things that we've been working on at our FQHC are these resiliency groups, which is actually an arm of our study that families were randomized to. For the Pearl study, these resiliency groups, we call them resiliency clinics, were in person, but we've been fossil enough under the direction of Dr. Joanne Jung to now have virtual resiliency groups, which are made up of dyadic pairs of caregivers and children. There typically are 4 to 6 dyads within each resiliency clinic. And our evidence from the Pearl study, although our numbers were large, have shown that having group visit models for resiliency within primary care are feasible, are acceptable, and our focus groups have demonstrated that families love them, right? Because they're able to learn the science of ACEs and toxic stress. They're able to have a community, a social group for support, and they're able to learn skills, right? And whether those skills are children understanding their upstairs brain versus their downstairs brain, or being able to name on their body where their stress is. I want to share one vignette of a young boy who was really struggling. And when we talked about where the stress lays in his body, he was able to articulate, he was 8, that the stress is in my hands and then I hit, right? And sometimes just knowing where the stress lives is part of this journey of healing and then being able to re-regulate. Our clinics also have social workers. We never have enough. And we have lists of community-based mental health resources that we can refer families to. Next slide. Being that we were able to get the Pearl screen, and I wish I could do a happy dance with all of you, at the Pearl screen is the only screen that is currently being reimbursed by a state government for screening for ACEs and trauma. In order to get paid for doing the Pearl screen, qualified Medicaid providers need to attest to doing a training. We do have a training that was done by our Department of Psychiatry that can serve as the training that you attest to, but there also is an online training, and there are links in this presentation for any providers that have not done it. In order to draw down on the payment, I just want to say once again, all providers need to attest to have been trained. Next slide. There are a couple key requirements for payment. And those requirements are knowing which patients are eligible to be screened. And again, it's annually for children, once in a lifetime for adults. The payment rate for reimbursement is $29. And in order to bill, we were able to create healthcare common procedural codes. And so there's a G code for a Pearl score that is 0 to 3, and a G code for a Pearl score that is 4 or more. And please note that these scores are based upon part 1, not part 2 of the Pearl screen. Next slide. When we formed ACEs Aware, we had a big, bold, audacious goal to reduce exposure to ACEs and toxic stress in half by 1 generation. The work has gained so much momentum that as in October of 2021, the ACEs Aware work has now moved to the UC system, which is just a huge accomplishment, not only for officers in general, but also for all the work that's been happening on the ground. And so the ACEs Aware is now transformed as of October into the UCLA UCSF ACEs Aware Resiliency Network, otherwise known as UCAN. There's a PI, an adult PI in San Francisco, Dr. Eddie Mochinger, and my colleague, Dr. Anda Kuo, and I are senior advisors for this initiative. And so UCAN, it's a multi-campus initiative that will really leverage the substantial interdisciplinary resources of UCLA and UCSF to screen patients for ACEs and to develop, promote, and sustain evidence-based methods to address the impacts of toxic stress in ACEs. Being able to ground the ACEs work in an academic home creates a value add, not only for equity, but also helping us to better manage disease by understanding the root cause. So beyond sort of what's happening at the state, we also are really fortunate to be able to continue the science. And I'm going to pass it on to Dr. Tucker to talk about our upcoming vision for the science.
So as you've heard, we've kind of walked everyone through some of the evidence between ACEs and health outcomes. Dr. Long took us through how to actually implement this into practice. But we know that there are still a lot of limitations and gaps for moving forward. A big one is thinking through what are the health system changes needed to screen for social risk, like the training, the appropriate response and resources being in place, particularly in low resource clinical settings. If we think about our colleagues at community health centers, which are providing the predominant care for low income communities of color, we need to be sure that those settings are equipped to respond and feel adequately trained on these tools. We also know that there's limitations of population studies. While we've been able to show you that the report of ACEs and of PEARLS specifically is associated with health outcomes, there's a lack of data of understanding how these may play out at the individual level. And so really trying to risk stratify patients going forward, and also how to think about protective factors. And should we be screening for protective factors at the same time as we are screening for ACEs, so that we can work with families onto and amplifying those protective factors that might be already ongoing. So these are a lot of questions, and some of them we're hoping to answer under the CARE study, which is the collaborative approach to ACEs screening and resilience study. Here we've partnered with several community-based organizations, including the Santa Barbara Neighborhood Clinic and Lifelong Medical Clinic, which are both FHQCs who also are community health centers. And we've also partnered with Futures Without Violence, which is a CBO really focused on bringing universal education and resources and training to low resource settings. This partnership has been formed to, one, continue follow-up of the PEARLS participants. It's also to further test a caregiver child intervention, and not just look at some of the behavioral responses that we see with a caregiver child intervention, but also to see if we're seeing evidence of change in biology. Because we know a lot of these outcomes that we're talking about don't happen to adulthood. And so having evidence early on that these interventions are effective would help build the argument for being able to make these more widely available and have reimbursement structures tied to them. And then lastly, it's to create a toolkit for low resource settings around training and implementation and building out resource guides. So stay tuned. We'll be excited to share that work with this group once we learn more. And then lastly, just wanted to thank all of our collaborators and colleagues that have been a part of the PEARLS family. It's really a growing family. And thank you all for listening today.
So we have a couple of questions that we have about 60 seconds for. So Meg, I want to answer your question about, the question is, do you have any data about the efficacy of the virtual resiliency clinic versus in-person sessions that you did pre-pandemic? This is such a great question. And so I do want to say that we have funding from the Governor's California Precision Medicine Award to look at interventions. And the exciting thing is that we can look at these types of interventions across our region. And so in Santa Barbara, in Richmond, in Oakland, and in San Francisco, it's not necessarily going to be able to be a comparative study between in-person and virtual, because all of our interventions at this point are virtual, but hopefully we will go back to in-person. And so it's a great thing for us to think about. Dr. Tucker and I are happy to share our presentation, and there are references on each slide. And yes, of course, there's an opportunity for screening in the inpatient setting, and please just email both Nita and I, and we can talk about this more.
Thank you both so much. It's exactly 1 o'clock. So thank you so much. I'm sure there's more questions coming up, and hopefully we can hear back from you in sometime in the future to hear sort of the follow-up on where this great work is going. I'm going to close it off. I'm not sure if Dr. Hirsch is still on, but I'm going to close it off by wishing everybody a good afternoon and reminding people that there is no grand rounds next week for no particular reason whatsoever than that we had somewhat of a last minute cancellation and we all can have a week without grand rounds. Dr. Hirsch, did you want to have the last word here?
I just want to thank both Nita and Dana for a wonderful, very interesting presentation, very important to us as pediatricians and of course to our community. So thank you, and thanks for participating, everybody.